Numerous studies have demonstrated that ultra-mutated endometrial carcinomas are associated with an excellent prognosis. Therefore, accurate identification of these tumors has important clinical implications. However, the methods for recognizing these carcinomas remain unclear to many pathologists. In today's lecture, we will focus on ultra-mutated endometrial carcinoma, what these tumors are, and how to test for and identify them. Histologically, endometrial carcinomas are broadly classified into low-grade and high-grade tumors. Low-grade tumors include grade 1 and grade 2 endometrioid adenocarcinomas. High-grade tumors encompass a wider range of histologic types, including grade 3 endometrioid adenocarcinoma, serous carcinoma, clear cell carcinoma, and mixed carcinoma containing serous, clear cell, or both components. Other high-grade tumors include dedifferentiated and undifferentiated carcinomas, carcinosarcomas, neuroendocrine carcinomas, and mesonephric carcinomas. Overall, approximately 85% of endometrial cancers are low-grade, while the remaining 15% are high-grade. In addition to histologic classification, endometrial tumors are also categorized by clinical and pathologic stage, which reflect how advanced the disease is. High-grade tumors are more aggressive and more often diagnosed at a more advanced stage. In recent years, molecular classification has gained increasing attention, as it can offer valuable insights into tumor biology and help identify candidates for targeted therapies. A significant portion of a pathologist's work involves tumor classification and pathologic staging. These assessments are essential for risk stratification, treatment planning, and prognostic evaluation. In most cancer cases, histologic grade and clinical or pathologic stage correlate well with prognosis. However, endometrial cancer often deviates from this paradigm. Molecular classification is superb than histology and clinical stage in predicting prognosis. In endometrial cancer, molecular classification has been shown to correlate more strongly with prognosis than traditional histologic classification or tumor staging. Based on molecular features, endometrial cancers are categorized into 4 groups: ultra-mutated, mismatch repair, MMR deficient, p53 abnormal, and no specific molecular profile, NSMP. Among these, ultra-mutated tumors are consistently associated with an excellent prognosis, significantly better than that of the other 3 molecular subtypes. Today we are focusing on ultra-mutated endometrial carcinomas. Histologically, ultra-mutated endometrial carcinomas exhibit a wide range of morphologies, spanning from low-grade to high-grade tumors. As shown in this figure, they can present as grade 1 or 2 endometrioid carcinoma, grade 3 endometrioid carcinoma, clear cell carcinoma, carcinosarcoma, dedifferentiated and undifferentiated carcinoma. Ultra-mutated endometrial carcinomas account for approximately 7 to 10% of all endometrial cancers, and it is more concentrated in high-grade tumors, comprising about 15 to 20% of high-grade carcinomas. They tend to occur in younger patients, with a mean age between 54 and 64 years. These tumors often exhibit lymphovascular invasion. However, despite these aggressive histologic features, ultra-mutated carcinomas are associated with an excellent prognosis. Let's take carcinosarcoma as an example. Among endometrial cancers, carcinosarcoma is considered one of the most aggressive subtypes. As illustrated in this figure, both overall survival and disease-free survival are significantly worse for carcinosarcoma compared to other high-grade endometrial carcinomas. However, if we use molecular classification and look at carcinosarcoma with POL mutation, the story changes dramatically. About 7.5% of carcinosarcoma harbors POL mutation. POL-mutated carcinosarcoma is associated with excellent prognosis, similar as that of POL-mutated endometrioid carcinomas. Essentially, for POL-mutated endometrial cancers, histologic grade doesn't change prognosis, and that all POL-mutated cancers belongs to the low-risk category for treatment purpose. These findings are supported by a recent study published in Modern Pathology in 2025. In this cohort, 10 out of 11 patients with ultra-mutated carcinosarcoma remain disease-free during follow-up, with no recurrences or disease-related deaths, even among those with advanced stage disease, stages 3A and 4B. The message is clear: ultra-mutated carcinosarcomas exhibit a markedly different clinical behavior compared to their non-POL-mutated counterparts. Their excellent prognosis suggests that these patients may be candidates for de-escalated adjuvant therapy, or potentially no adjuvant treatment at all. For pathologists, the key question is, how can we reliably identify POL ultra-mutated tumors so that patients can benefit from molecular classification? Unfortunately, this remains a significant challenge. POL ultra-mutated endometrial cancers exhibit a wide range of histologic appearances, spanning from low-grade endometrioid carcinoma to high-grade, including undifferentiated and dedifferentiated carcinomas. Although POL ultra-mutated tumors are not morphologically distinct and cannot be identified by histology alone, studies have shown that they may share certain histopathologic features. Let's now take a closer look at these histologic features. These features include ambiguous morphology, the presence of more than bizarre nuclei, marked tumor-infiltrating lymphocytes, and p53 subclonal overexpression and MMR subclonal loss. Ambiguous morphology refers to histologic features that are indeterminate or do not clearly fit into a specific diagnostic category. As illustrated in this image, the tumor exhibits overlapping characteristics of both serous and endometrioid carcinoma, making it difficult to confidently classify based on morphology alone. Moderate to marked intratumoral and/or peritumoral lymphocytes are also commonly seen in POL ultra-mutated cancers. Another feature is the presence of bizarre tumor nuclei, which can be mononucleated or multinucleated. Subclonal expression of p53 protein and/or MMR protein was observed more often in POL ultra-mutated cancers. However, it's important to emphasize that none of the pathologic features we've discussed, such as ambiguous morphology, bizarre nuclei, tumor-infiltrating lymphocytes, or subclonal abnormalities in p53 and MMR expression, are either sensitive or specific for POL ultra-mutated tumors. While these features may be more frequently observed in POL-mutated endometrial cancers, they are not exclusive to this molecular subtype. They can also be seen in non-POL-mutated tumors, and conversely, POL-mutated tumors may completely lack these features. Therefore, the only reliable method for identifying POL-mutated tumors is through molecular testing. Although universal molecular testing for all endometrial cancers is not yet feasible in routine practice, we are steadily moving in that direction. Currently, the recommended approach is risk-stratified testing. On biopsy specimens, if the tumor appears to be low-grade endometrioid, with wild-type p53 and intact MMR, POL mutation testing is generally not necessary. These tumors are typically low risk, and adjuvant therapy is often not indicated. However, if any high-grade features are present, such as high-grade histology or abnormal, mutant, p53 expression, then POL mutation analysis should be performed. On hysterectomy specimens, if the tumor is low-grade, stage IA, shows no lymphovascular space invasion, LVSI, and is p53 wild-type, the patient is likely cured with surgery alone, and molecular testing for POL mutation is usually not indicated. In contrast, if the tumor exhibits any aggressive features, such as deep myometrial invasion, beyond stage IA, LVSI, p53 mutation, or other high-risk characteristics, POL testing should be pursued to refine risk assessment and guide adjuvant treatment decisions. Some may wonder, why put so much effort into identifying POL mutations? Does it truly matter for patients? The answer is a resounding yes. Detecting POL ultra-mutated tumors profoundly influences patient management and outcomes. Currently, about 83% of patients with POL-mutated endometrial cancer receive adjuvant therapy. While adjuvant treatment can be effective, it also carries significant toxicity. Emerging evidence increasingly supports that patients with POL ultra-mutated tumors, due to their excellent prognosis, can often safely avoid chemotherapy. Accurate molecular classification thus plays a critical role in preventing overtreatment, sparing patients from unnecessary side effects, and still achieving outstanding outcomes. In summary, POL ultra-mutated endometrial cancers exhibit a range of histologic features, from low-grade to high-grade, and even undifferentiated tumors, yet all are linked to an excellent prognosis. Certain histologic characteristics, such as ambiguous morphology, tumor-infiltrating lymphocytes, bizarre nuclei, and subclonal biomarker abnormalities, tend to be more common in POL-mutated tumors. However, none are specific enough for definitive diagnosis. Therefore, molecular testing remains the only reliable method to identify POL mutations. Importantly, recognizing POL ultra-mutated endometrial carcinoma has significant prognostic and therapeutic implications for patients.